professor, excuse me, in the Department of Infectious Diseases. And he will actually be doing a critical appraisal and using a health economic study for the same. And I'm going to hand over to Dr. Kurian to actually moderate that.
Congratulate you for taking up this economic issue. So, economics papers in medicine are fairly poorly understood by the general population. And I think it's very important that you sensitize the population regarding the issues regarding the critical appraisal of economics. Go ahead.
Thanks. This is the first time I'm appraising the health economic study. So I'll try to do my best. So why economic analysis of economic health study is important? Because it addresses both the cost and the consequence of strategies being compared, and it able to decide whether the benefits what the healthcare costs, and it also help us to minimize the cost for the strategies we are using. And at the end, it helps us to establish a health policy at the institution level or at the national level. So this is the article I'm going to appraise, published in Lancet Global Health, to study or assess the impact and cost effectiveness of short course tuberculosis preventive therapy. It is weekly 3 months isoniazid and high dose rifampicin for household contacts and people with HIV in 29 high incidence countries, including India and Indian neighboring countries. So they included 4 different populations. One is HIV and less than 5 years, and also they included the population more than 5 years of age, 5 to 15 years, and more than 15 years. And they compared the combination of contact investigation and tuberculosis preventive, short course tuberculosis preventive treatment, that is 3HR, weekly 3 months high dose isoniazid and rifampicin, versus no intervention. We can look at what are the cons or concerns at the end of my presentation, and the outcome they selected is as of any cost analysis study, it is ICER, that is incremental cost effectiveness ratio, between 2023 to 2035. In the next decade, how the cost effectiveness going to be. So before going into the cost effectiveness, we want to know whether these short course TB preventive therapy is effective when compared to current strategies. So it happened a decade ago after this landmark trial that is Sterling et al. Published in NEJ in 2021. He compared these short course high dose INH and rifampicin regimen with the 9-month daily self-administered isoniazid. He included TB HIV patients along with less than 5 years of age, and he studied the outcome is confirmed tuberculosis through culture and clinical TB in less than 18 years, and it's a non-inferiority study. What we found was these short course TB preventive regimen is as effective as 9-month isoniazid monotherapy, both in MIT and per protocol population. But one thing what we obviously what we noted is the rate of treatment completion is better with short course regimen. And even the hepatotoxicities are a little bit lesser in a short course regimen. So these 3 months of directly observed once weekly therapy of high dose rifampicin, that is 900 mg, and high dose isoniazid, that is 15 to 25 mg per kg, weekly dose is as effective or as effective as self-administered daily isoniazid. So is it effective or as effective only with the 9-month isoniazid? No, even when we looked at compared with multiple other regimens in meta-analysis, it looked like it is as effective as multiple other regimens, multiple other longer regimens with isoniazid or isoniazid rifampicin combination. And when you look at the completion rate, it is twice better than long-term regimens. So that is a catch with these short-term regimens. The completion rate is much better when compared to long-term regimens with with better hepatotoxic outcome. So weekly 3HP regimen is better option, especially better completion rate and short duration. So coming to cost-effective analysis, not the study I'm going to appraise. This is this is the cost effectiveness modeling included 1,000 patients. It's a modeling study. So before any cost effective study, we need to understand this cost effectiveness plane. So there are 4 quadrants. This is quadrant 1, quadrant 1, 2, 3, 4. So quadrant it's the in the y-axis it is cost difference from the center control, and in the x-axis it is the effectiveness. Whenever our intervention falls within quadrant 2 or quadrant 4, that means one of the intervention is dominant. For example, our intervention falls in quadrant 2, that means it is effective and cheaper. So there is no doubt our newer intervention is the cost effective. If our intervention falls in the quadrant 4, that means it's costlier but less effective. So the control is dominant. So no more ICR evaluation. But if our intervention falls in quadrant 1 or quadrant 3, that means if it is quadrant 1, it is costlier, but it is effective than our control. If it is quadrant 3, it is cheaper, though it is less effective. Then we need to evaluate with incremental cost analysis. I will come to that later. So if you look at these cost effective analysis, when we include all the TB preventive regimen, it looks like this shorter regimen, especially this self-administered therapy with 3 HP, looks like cost effective. And after that, after these results, the WHO also extended its inclusion of TB preventive therapy beyond PLHIV and 5 years age group to more than 5 years age group in household context of patients with pulmonary tuberculosis. And as we already looked at previous presentations, we have high burden. We are the high burden countries, and when we look at the TB preventive therapy, as a percentage, we contribute a lot for TB preventive therapy. Though we have achieved the TPT goal in PLHIV patients, but when coming to other age groups, we are falling behind. So coming to my study, where we are going to look at these 4 populations, comparing non-intervention versus combination of contact investigation and TPT. So these are the countries, these are the 29 countries that were included in this modeling study, where you can see more than 50% of the countries were sub-Saharan, and India and neighboring countries and Indonesian countries. And these are the decision tree and the transition models they looked at, because we need to tag a cost to each and every pathway in each intervention, what we're going to do. If you look at only difference between the contact and the TPT treatment and with compared to less than 5 years and more than 5 years. In less than 5 years, we're going to stop at the level of X-rays, and then we're going to decide whether we want to treat as a TB if there's a chest X-ray and symptoms are positive, or we are going to give TPT. So whereas in more than 5 years of age, we are going to do extra molecular testing to rule out active tuberculosis, because it's going to increase the cost. And PLHIV as a programmatic regimen, it's 4S symptom analysis, X-ray, and then we will decide of TPT and tuberculosis therapy. And also, if we're going to give TPT therapy, whether going to complete the regimen or they're going to stop, and they also factored in the costs that are going to happen for the OPD visits and the complications. And this is the Marco model. We need to, because to study the outcome and put a cost into it, we need to know what are the notification rates, what are the reactivation rates. And so that also in this study they looked into it. These are the model parameters they looked at. They looked at very carefully each and every factors, including TPT efficacy, what are the complete TPT 3 HP completion rates, what are the cost of 3 HP, and also they looked at daily 1 month HP regimen also in sensitivity analysis, and they carefully looked at the cost of these regimens as per 2020 US dollars, and it's right. And these are the other model parameters they looked at. They looked at carefully most of the things. And these are the country-specific model parameters at that time. They looked at each and every cost, chest X-ray, outpatient visits, inpatient visits, TB cost, and what are the background treatment according to each ages they looked at. When they looked at when they factored in everything, and when they looked at when they compared, I don't know whether everyone can see. So the first column is no TPT, no TB preventive therapy. The second one is with the TB preventive therapy, and the third column is what are the extra cost that's going to cost in this four different population. It looked like, obviously, when compared to no TPT, all the population is going to incur a particular cost, and more or less all the population had a similar cost increment. But when you look at the PLHIV patient, it looked like if you give TPT regimen, we are going to lesser the cost of ATT. So we are going to, there is some impact on reducing the TB treatment. When we looked at mean per person health impact on scaling up of 3 HP for PLHIV and other household contacts, the impact of the case averted when we give TPT, it's not that much high in other age groups other than less than 5 years. When we compared less than 5 years versus all others, the number of case averted, the number of death averted in age group less than 5 is significantly higher than other age groups. So it looks like when we compare no TPT versus TPT, the impact is going to be more in age group less than 5 years. And just extrapolating these findings, when we look at these ICR model, so this is first quadrant, as I told you before. These are costlier and effective intervention, and these the slanty bars are the threshold, that is ICR threshold. For example, for these the right corner bars, or the threshold of $100 per DALI aversion, and it goes up. So it looks like these the chart A, that is for age group less than 5 years, it looks more effective when compared to 5 to 14 years and more than 14 years and PLHIV. So overall, it looks like in younger population, if you give TPT when compared to no TPT, it's more cost effective. And they looked at what will happen if you implement these intervention, what will happen, how much it costs, how much proportion it takes to the TB budget. It looks like when we implement these, especially these 3 HP model, it costs nearly 1/5 of annual TB budget of a country, especially in India. It's going to cost nearly 30% of our TB budget. So we already have a lot of things to deal with, but we need to think about whether, because they are comparing no intervention, they're not comparing, I'll come to that, they're not comparing already the intervention that's ongoing, whether we need to incur this much amount of cost to our TB budget, we need to think about it. And I'll just skip it. So coming to sensitivity analysis, they looked at multiple parameters, which is reasonable. So they looked at three, this intervention, this is 3 HP price, when it will become more effective to become a cost effective. It looks like when the x-axis is the 3 HP price full course USD, US dollars. So especially for PLHIV patient, to become a cost effective, the full course should be less than $10. So as per the study, they assumed it is $12 to $15 for full course. So it should, for others, though it is cost effective for HIV patients, needs to be very less cost to complete the full course. And also they looked at other long horizon, lower TPT coverage, no X-ray, no TPT, and transmission rates. Overall, in sensitivity analysis, they looked at if the 3 HP coverage is less than 50%, it's going to be lesser cost effective. When we look at our Indian data, For example, our 6 months isoniazid prophylaxis in our patient, it's around 40 to 60%. Is better in some of the states, but it's most of the states it's around 40 to 60%. So even if you implement this costly intervention, if the coverage is less than 50%, it's going to be less cost effective. And whenever you give this intervention to a population where the ART adherence is high, the 3HP is going to be lesser cost effective, because whenever the ART coverage is good, we are going to prevent a lot of tuberculosis cases. So in this population, if you give this costlier, though they are saying it is cost effective, this intervention is not going to be work. And when they compared with the 1 HP regimen, it's obviously a 28 dose when compared to 12 doses, it's more costlier. And increasing monitoring visits doesn't change much. And when they factored in the lesser transmission rates, it looked like it is cost effective. So overall, looked at the validity of this study. They looked at a programmatic view, and they include multiple ages, including PLHIV. And the cost measured accurately, I'll come to that. Yes, whatever the factor they have integrated, it's accurate, and they reasonably they looked at multiple variables for sensitivity analysis. But I have some concerns in this study, because already we are using a regimen. For example, by using isoniazid monotherapy. So I would have loved to see when they compared with some intervention and they studied in my setting. But whereas they compared with no TPT, obviously is going to be effective. So they should have compared with some with an intervention rather than no intervention. And also toxicity, I felt that in this study, they undermined the toxicities. So when they factored in the toxicities for 3HP, the maximum assumption was 2%. I will go back to the landmark trial by in NEJM. For them, in the study, the adverse effect was 3.7% in isoniazid only, whereas 4.9% combination therapy, whereas in this study, they assumed 2%. And also a special, very unique problem is happening with 3HP, that is hypersensitivity reaction. So when compared to isoniazid, it is 0.5, whereas in combination therapy, it is 3.8. And other drug reaction is 1.7 and 3.2. So there is something else is happening that is not factored in this cost analysis. And also not only some of the centers, they have already rolled out 3HP in India. There they have noted nearly 20% of household contacts, especially in Delhi, they noted dizziness. They are saying that the pharmacokinetic is also approving that is due to high dose isoniazid rather than rifampicin. And other issues I see is it's coming as a fixed dose tablet, 900 mg and 900 mg of rifampicin isoniazid in our Indian population who are already low weight. Is going to cause more toxicities and acetylation status when we looked at with respect to isoniazid. Our population, we have more of slow acetylase, so then more toxicities. And pyridoxine, why they're not giving pyridoxine when they give isoniazid? And also isoniazid high dose can precipitate serotonin syndrome. And when coming to rifampicin, drug-to-drug reaction, whether we need to give double dosing of dolutegravir when we give rifampicin, but most of the studies show that single dose is enough, but multiple PK/PD data shows that when we give a single dose dolutegravir with these 3HP regimen, the trough concentration reduces by 50%, though the median values are above the target. So there is a concern about this PK/PD. So whether they are better than our isoniazid monotherapy, it's still a question. And drug resistance, what will happen in a population where the INH mono resistance is 5 to 10% on a long horizon, whether it will create a problem, we don't know. So overall, 3HR is marginally cost effective than other TB preventive therapy, needs more data in our setting. For PLHIV patients under NACO program, which is effective, rigorous follow-up in most of the states. 6 months Hyzon is as effective as 3-HP with the concerns of drug reactions and drug interactions. Whether I need to add these newer regimen, I may not. But whereas in non-PLHAV population, especially is less than 5 years of age, this short course may be effective because of higher completion rate. So whenever many further cost-effective analysis, they need to factor in these drug-to-drug interactions and the systemic reactions when they are studying 3-HAR regimen. Thank you.
Selwyn, when you complete a critical appraisal, you have to answer 3 questions. First question is it internally valid? You have answered some of that. The second question, is it generalizable to your situation? And the third question is, will you now recommend it to your health secretary or to the minister based on the results of this data? So these are actually those 3 things are very important. And in economics, there are, just like any other design, there are some specific questions you require to answer. That part you did not look at. I could share it with you sometime, maybe send you an email about what are those specific questions. One of the important questions is whose perspective is the study done? Any economics, there are 3 perspectives. One perspective is the patient. For example, how much can you or need to spend or to pay to get the thing? The second question is the provider. How much is the provider willing to spend? And the third question is society, which includes all of them. So much of this, actually, if you make a decision, the perspective is very important, because if you want to say, at the end of this, you said it costs $200 per quality of reducing quality of life reduction of 1%. If you want to compare across health interventions for that, isn't it? Now, for first thing is, if you want to compare this health intervention with a quality of 300 or 400, you just say, what about a vaccine strategy? Not for HIV, I mean, not for across the health sector, a vaccine costs $2, it's in single digits. And a preventive strategy for HIV, including condom promotion and STD treatment and education, costs around $20. You're talking about $300. So from a provider's perspective, he has to decide how much will you spend. And you have currently, if somebody is spending 15% of your total income or your budget onto health, then it makes to some extent. But we are spending less than 1%. So one way of generally, one way of understanding about cost effectiveness is approximately you have a value. For example, less than 2,500, we would say it is cost effective. But as part of 2,000, or it's a part of a GDP. There are various ways of looking at it. But GDP is totally meaningless in India, because GDP of India is 2,500 rupees per person. But actually, a villager in India will get you 150 rupees only. So economics has to have a specific issue. So for first thing is, based on this perspective issue, and if you are asked presenting it to a policy decision-making body, we need to understand, is the cost effectiveness the right approach to this, or is it cost benefit? Because you want to compare across different health interventions to understand whether we will spend this money or not. Okay, there are other issues like timing, discounting. Then you talked about sensitivity analysis. But there are other issues as well in economics which requires to be touched upon. Just like, how will you do critically evaluate an RCT? Economic evaluation requires to address around 4 or 5 questions. And that we can read it up, or you can send it to you. You can have a look at it.
Sure, thank you.
May I request all the 3 speakers to come onto the dais? We'll have a very short Q&A session. So every speaker just gets 1 question, because I think we're really behind time. So may I request Dr. Rajiv, Dr. Prasanna, and Dr. Selwyn to come up onto the stage, please. Since I'll just start with Selwyn. So Selwyn, I think Dr. Kurian asked those three pertinent questions. So if you were to kind of tackle his questions based on the reading that you've done, you did look at some of the qualies and look at the TB budget as a whole. And you mentioned that you felt that it would not actually be cost effective. So what is your take on, let's say, this, if you were to recommend as a policy to the government, what would be your take? Whether we should adopt it or whether we should continue with what is already existing in practice. So I think you dealt with quite a few of the things Dr. Kurian had mentioned, but maybe just for the audience to take away, what would be your take on this as a policy adoption?
Yeah, so when we look at this new intervention, uh, there is already ongoing TB preventive therapy like 6 monthly isoniazid, which is going fairly well. We are giving it for HIV patients and also in age group less than 5 years who have contact with PL-HIV. So when we compare with this intervention, that is the short duration, for HIV perspective, there are some concerns. One is it is not as effective. It is not superior to the current strategy. And also the interactions, because it's going to add more pill load, and also there is a concerns with side effects and interactions. So with this population, with PL-HIV population, I may not recommend this newer regimen, whereas in age group less than 5, because it's 12 doses weekly and high completion rate, because they are not also under any particular program. So in this patient, I want good adherence and good completion. So I may recommend this short duration for less than 5 years, but not for PL-HIV patients.
Okay, thank you. Thank you for that succinct summary. My next question is to Dr. Prasanna. What is the role of high-dose meropenem in carbapenem-resistant organisms?